Excellent. Well, thank you everyone for taking time to stay with us here. We're really excited for our last presentation. I know there's been a lot of questions on the impact of HIV on the brain, so we're excited about Dr. Farhadian's practical approach. Dr. Farhadian is an infectious disease specialist who cares for people with a range of different infections, including Lyme, HIV, and syphilis, and she has additional expertise in the management of neurologic conditions and neurologic infections. As an associate professor of medicine at Yale School of Medicine and an associate professor of epidemiology of microbial diseases at Yale School of Public Health, she studies how infections like HIV and COVID-19 affect the central nervous system. She collaborates with colleagues in neurology, geriatrics, and public health to bring a cross-disciplinary approach to her work. She completed her medical training at Weill Cornell and a doctorate degree at the Rockefeller University in New York City, and completed her internship and residency in internal medicine at Yale New Haven Hospital, followed by a fellowship in infectious disease at Yale. We're really excited to hear her practical approach. There's already some questions that had come in the pre-questions, so I think we will have lots of enthusiasm.
Great. Well, thank you so much. And I'm really delighted to be with all of you and to talk about something that's near and dear to my heart. I don't have anything to disclose. Here are the learning objectives. I hope to talk a little bit about some of the science behind how HIV affects the brain, and then really move on to identifying modifiable clinical and lifestyle risk factors that are important for us to recognize as providers, because they represent opportunities to intervene on cognitive decline among older adults with HIV. And then really get into a practical evidence-based approach to evaluating cognitive symptoms, and how and when to use screening tools and laboratory tests and specialty referrals. So let's dive right in. And I want to start with a case that probably feels familiar to many of you who are taking care of older adults with HIV. So this is a 58-year-old man with long-standing HIV infection who is presenting with several years of memory problems. This gentleman was diagnosed with HIV in the 1980s and started on ART in the early 1990s. His CD4 at the time of starting treatment was quite low at 55, but currently his CD4 count is 350. His CD4 to CD8 ratio, which you'll notice I'll talk about again later, remains low at 0.6. So in normal cases, it would be greater than 1 and even greater than 1.5, but his viral load is undetectable. He is additionally on medications for high blood pressure, high cholesterol, and chronic back pain. He lives alone, and he reports that he doesn't have any close friends really in his life. And his neurological exam in the clinic reveals a slow gait, but normal reflexes, and otherwise no focal deficits. So this case really reflects a common conundrum in the care of older adults with HIV, which is, does my patient have a brain problem? If so, is it related to their HIV, and what can I do about it? So let's dive right in. Why are we even talking about HIV in the brain? So in the last 10 years or so, our knowledge of how HIV affects the brain has grown tremendously. We know, for example, from studies of people with acute HIV infection, that HIV enters the central nervous system within days of infection and can be detected in the CSF very soon after a person acquires HIV. So within 1 to 2 weeks in most people. If left untreated, HIV will replicate in the brain, will cause injury to the brain, and ultimately, in a subset of the individuals, will lead to neurological syndromes, including dementia. And so that's all what we expect to happen in the absence of ART. And indeed, in the early days of the HIV pandemic, prior to the widespread use of ART, HIV dementia was the defining manifestation of AIDS in about 5% of people. This was typically a manifestation of late-stage disease that presented in people with low CD4 counts. Clinically, HIV dementia, which is also called AIDS dementia complex, is different from other dementias in that it presents with a constellation of cognitive, behavior, and motor symptoms. And what's interesting is that there are typical findings on brain autopsy of people who have HIV dementia. These are important for us to know about because they tell us something about how and why HIV is affecting the brain. And so the kind of classic findings are abnormal immune activity, typically reflected in abnormal microglial cell activation, as well as a loss of neurons and a diminishment in brain volume. But again, this is extremely rare in people who are on ART. This is something that was way more common in the older era, and that we now see maybe a couple of times a year in the hospital in people who are presenting with a new diagnosis of HIV, and again, is not commonly seen in people who are on suppressive antiretroviral therapy. However, more subtle brain changes are common in people with HIV and these on ART, and these may persist even despite decades of ART. And I'm just giving you two examples here of some of the interesting research that's informed our understanding of this over the last several years. Here on the left, I'm showing you a study of brain MRIs that were used to calculate a brain age based on imaging findings. And so in this study, they found that on average, people with HIV had older brains compared to people without HIV. But I want to point out, though, that there is obviously quite a range here, as you can see, and that this phenomenon does not affect everybody with HIV equally. And similarly, in studies from our group and in many other groups, we've looked at inflammatory proteins in the spinal fluid, in the CSF of people who have been on treatment for, in the case of this study, an average of 19 years. And what we found was that there remained abnormally high levels of inflammatory proteins in spinal fluid, again, despite ART. And this suggests that there continues to be an ongoing abnormal immune reaction in the central nervous system in people with HIV who are on ART. But what we don't know and don't have a good estimate for is the true impact of HIV-related cognitive impairment in the era of ART. I'm not going to spend a lot of time on this on the epidemiology today, but I do want to mention that it's increasingly clear that HAND and the HAND criteria are very likely overestimating the percentage of people with HIV who have cognitive impairment. So many of us kind of were educated or taught to use HAND as the way that we would think about someone with HIV and a possible cognitive disorder, so HIV-associated neurocognitive disorder. But these HAND criteria were designed for research purposes, not for clinical assessments. They include people who have quote unquote asymptomatic cognitive impairment, which is of questionable clinical significance. And using HAND criteria, anywhere from 20 to 60%, even up to 90% in some studies of people with HIV would be classified as being cognitively impaired. But I think people on this call who take care of people with HIV would find that that number really does not align with our own clinical observations in clinic. And so because of this, there's now been a movement within the neuro-HIV community to come up with a new approach for identifying and classifying cognitive impairment in people with HIV. And I'm pointing you here to a really fantastic review article that kind of goes through all of this. And I'd encourage anybody who's interested in this topic to read that. What we do know, though, is that in contrast to HIV-related dementias, people with HIV remain at higher risk for the development of age-associated dementia. So these are more typical dementia, Alzheimer's dementia, Parkinson's, Lewy body disease. And what we've learned from large-scale epidemiologic studies, including some, I think, really fantastic studies from Kaiser Permanente, led by Jennifer Lamb, are that the prevalence of dementia is higher in people with HIV compared to people without HIV, and this is after adjusting for comorbid conditions. And the incidence of dementia is higher in those with HIV compared to without, along increasing age. So something about having chronic HIV infection, even on suppressive ART, increases the risk for any age-associated dementia. And it's important to know that certain conditions elevate this risk of developing cognitive complications in people with HIV. I like to think of these as factors that pose a risk to cognitive health that are not related to HIV and that are present in could be present in anybody, but are also present in people with HIV, and that those that are specifically HIV related and that as HIV providers, we need to be especially attuned to. So for example, HIV related risk factors such as having had a low CD4 nadir, having had a low duration of infection, having a persistently low CD4 to CD8 ratio, these are all risk factors for having cognitive complications during HIV on ART. In terms of comorbid conditions, I've listed many here that we know from studies outside of HIV are important risk factors for developing cognitive complications. What I've done in both cases, though, is bolded those risk factors that are potentially modifiable. What I want to point out is that we have risk factors for cognitive complications where that present opportunities for us to intervene and reduce the risk. Within the HIV-related risk factors, the one I'll highlight is efavirenz use. So we know from switch studies in which people who are on an efavirenz-based regimen and switch to a dolutegravir-based regimen, that those individuals experience an improvement in cognitive performance after making that switch, suggesting that efavirenz has an effect on brain health. And within comorbid conditions, I want to highlight especially hearing loss, social isolation, and sleep apnea as factors that we don't always inquire about, but which are in many cases easily modifiable and can in fact improve performance on cognitive testing in those that receive the services they need for that. All right, so let's go to our first practical question. Since we know that people with HIV are at higher risk for cognitive problems, should we be screening asymptomatic older adults with HIV for cognitive and mental health disorders? And so we got our first audience response question here. What is the current IAS-USA ARB guidelines panel position on screening asymptomatic older adults with HIV for cognitive or mental health disorders? And so go ahead and make your vote. Yes. Okay. So we have a split here. And in fact, 44% of you were right. The IAS-USA ARV guidelines panel does not make a specific recommendation for or against screening. Okay, why don't we skip past this slide? Because I think the point here is just to say that the various societies make pretty weak recommendations on what to do, which I think reflects the fact that the research really just doesn't tell us that there is or is not a benefit to doing these screenings in asymptomatic adults. And that's really in contrast to mental health screening, where there's better evidence and where there's a stronger recommendation for screening at routine visits. Next slide. Okay, so next question. Again, moving on to a more practical situation, how should we clinically approach an older adult who comes in with cognitive complaints? Next slide. And I'd like to propose that we take a systematic approach here. So next slide. As with all clinical complaints, we're going to start with the history and physical. And in this case, we really want to be focusing on questions that can help us get at some of the domains that are more prominently affected by HIV. So these include cognition, motor, behavioral symptoms, asking questions about, for example, gait. We also ask about time course. Is the person experiencing symptoms that are new, that are occurred in the last few weeks, or are these issues that have been going on for months and for years? This can help us determine whether we're dealing with a progressive process and also whether we need to consider more urgent referral for imaging or lumbar puncture, or if a watch and wait strategy would be appropriate. Next slide. Next, we assess the person's past and current medical problems. We start by asking about their HIV history. Again, how low was their CD4 nadir? How long did they have untreated HIV before starting ART? Knowing this is important because it can help us place the risk for HIV-related cognitive issues in context. Somebody who started treatment really soon after acquiring HIV, who never had a low CD4 nadir, who has a high CD4 CD8 ratio now is unlikely to be seeing the effects of HIV in their brain. It also, knowing this information can help us later when we're interpreting the brain MRI. So if a person ends up getting a brain MRI and has, for example, white matter hyperintensities, we may interpret that differently, knowing that they've had decades of uncontrolled HIV versus not. Um, we then move on to other medical issues. And again, we're really focusing here on this search for modifiable risk factors. And so we start with medications. What meds are people on? Are they on sedating medications? Are they simply on too many medications? How about sleep? Sleep deficiency is highly prevalent among people with HIV, but it's underdiagnosed and undertreated. We think about other comorbidities, hearing loss, social isolation. As I mentioned earlier, these are factors that, if we can begin to address them, can have a positive impact on brain health. Next slide. And then finally, we'll move on to a bedside cognitive assessment. There is no one right tool to use, and each tool has their limitations. So my advice is, in general, pick the tool that you're most comfortable with. I don't recommend really short screeners like the 3 questions test or a clock drawing test, because these have actually been shown to have very poor sensitivity when compared to gold standard neuropsychological tests in people with HIV. The MOCA does have available online a 1-hour training that you can do, which may give you extra comfort in using that particular test. But the key is to choose the one that you feel the most comfortable administering, and recognizing that each one has limitations. Next slide. Okay, so a really common question we get asked is, does my patient need a lumbar puncture? Do they need a brain MRI? This is not always a straightforward decision, but in general, the way that I approach this is I would have a higher consideration for obtaining a brain MRI and or a lumbar puncture if the symptoms came on more quickly. So if we're dealing with more of an acute or subacute presentation, if the symptoms appear to be rapidly progressive, if there's a family history or other clinical concern for a neurodegenerative process, if the symptoms are non-memory predominant, so we're seeing more of behavioral or gait issues, then we may want to more quickly move towards a brain MRI in those cases. And if there seems to be subacute confusion, inattention, fluctuation, again, we may consider imaging and the lumbar puncture more in those cases. But in general, if screening and basic labs are normal, if symptoms appear to be stable over a really long period of time, then a period of observation with management just by their primary care HIV provider may be a reasonable approach. And these are really, really reasonable questions to ask your colleagues in neurology as well. Next slide. All right, so now we have our second audience response questions. Please pull it up. Which of the following best describes the relationship between polypharmacy and cognitive health in people with HIV? And let's go ahead and see the answers. The question was too easy. That's exactly right. Polypharmacy may contribute to cognitive symptoms and frailty, and in one of the ways may be through drug-drug interactions. So next slide. Okay, let's talk about polypharmacy for a minute. This has come up earlier today, but it's so important to bring up because this is low-hanging fruit that many of us, myself included, don't take enough time with through the many other things we need to work on in a short clinic visit. As you know, older adults with HIV have, on average, more comorbidities than age-matched older adults without HIV. Having more comorbidities often leads to having more medications. And because of that, people with HIV have a higher rate of polypharmacy, meaning being on 5 or more medications. And this is actually true even if we take ART out of the picture. Even removing ART, people with HIV are on average more likely to have polypharmacy. This is problematic because polypharmacy means that there's more potential for drug-drug interactions, some of which can have neurological symptoms. And we know from our work, from Dr. Erlinson's work, from many other groups, that polypharmacy is independently associated with frailty, falls, slow gait speed, and other geriatric syndromes, even after accounting for multimorbidity. Next slide. So what can we do about this? At every visit, ideally, we're performing a medication review. So this is just the guidelines that come from EACS, and they really give a nice set of questions to consider asking, really for every medication that your older adults are on. Is there a need to be on this? Is this appropriate for an older person? Is the dose right in my patient whose renal function may have changed over the last several years, etc. Not all medications are equal offenders, of course, and we want to especially pay attention to CNS acting medications. Some of the major culprits can be medications that are used, for example, in the patient that I started the case with chronic pain. So gabapentin, pregabalin, um, uh, benzodiazepines, these are especially ones that we need to be attuned to. Next slide. Okay, I want to take a minute and talk about cerebral small vessel disease. And this is in line with what we've heard about earlier from our colleague in cardiology. Um, CSVD denotes a range of clinical, imaging, and pathological syndromes that result from various causes that affect small blood vessels in the brain. One of the imaging hallmarks of CSVD are white matter hyperintensities, and I'm showing you an example of that here, which you can see on a FLAIR sequence of MRI. These are really common in the general population of older adults, and maybe up to 70% of older adults will have some white matter hyperintensities on the brain if they were to get a brain MRI. But what's important to know is that HIV itself is an independent risk factor for cerebral small vessel disease. And having this increases the chances of having cognitive impairment in people with HIV. This represents a potentially modifiable risk factor because if a person has white matter hyperintensities related to small vessel disease, that's an opportunity for us to intervene to control vascular risk factors, to have more of an impetus to make sure that their blood pressure, their cholesterol is under control, to intervene on smoking. And we can show them the impact on the brain and an opportunity to improve that aspect of health. Next slide. And then finally, I want to take a minute to talk about zoster vaccination. We did get into this in the earlier talk on vaccines, but I just want to show you just how profound the effect has been in these epidemiologic studies. So I mentioned earlier today the Wales study, where there appeared to be a 20% relative reduction in dementia among adults who were eligible for the vaccine versus those who weren't. And you can see the birthday effect right there. So if this was the day that people born before were eligible to get vaccinated and the day after was not eligible, it's really quite a striking graph, I think. And similar findings have been seen in other cohorts that have also shown an association with a reduced risk for dementia in people who have received zoster vaccination, actually either with Zostavax or with Shingrix. Next slide. Okay, so back to our case. So not being able to tackle everything in one visit is common. So when this person showed up, we did some basic blood tests to look for reversible causes of dementia, syphilis, B12, etc. This person did perform poorly on the MOCA exam, losing points for attention and concentration. We did a medication review and found that he was taking pregabalin, was taking it in the morning. It was making him pretty sleepy and affecting his ability to concentrate during the day. We talked and made a referral to our social workers to discuss potential for engagement with some of the community groups we have, especially those that are supporting older men with HIV, which I've noticed in my own clinic is a group that's increasingly dealing with loneliness. And because of the low MOCA score and the vascular risk factors, we did refer him for a brain MRI. The plan for future visits was to talk about that neurovascular risk, especially when the MRI revealed white matter hyperintensities. We did refer to an audiologist to understand if there was a component of hearing loss here. You can get more deeply into sleep, asking questions about their sleep. And then in general, I like to repeat the MOCA about 6 to 12 months after making these adjustments to see if we've made an improvement. So after adjusting the pregabalin timing, having him take it at night, addressing sleep, addressing hearing. And if there continues to be an issue, then at that point, it's appropriate to make a referral for formal neuropsychological testing and consideration of cognitive rehab or other interventions. Next slide. Okay, and I again apologize for the technical glitches and for going a little bit over here, but thanks for your patience, everybody. Clearly, this is my last presentation I will ever be asked to give at the IAS-USA, so
Not at all. That was
let's make it
fantastic.
worthwhile.
Thank you, Dr. Farhadian. I was waiting in suspense to see what the MRI showed. Did your patient have anything on MRI, or was this
Yeah, so he had the classic appearance of white matter hyperintensities that we often see in people with HIV who have those low CD4, CD8s, had the low nadir, were off treatment for over 10 years. And it's difficult because you don't know if that's all just due to the HIV effect or if there's a vascular issue there as well.
And I think you mentioned the pregabalin, which and we know there's probably an association between peripheral neuropathy and cognitive impairment too. And it's so challenging to treat the pain from the neuropathy, but knowing that you may be potentially worsening cognition. So have you found
Very difficult, very
benefit just
difficult.
changing dosing
You
or the
know,
timing or?
dosing timing can be really important.
Mhm,
So, as you know, gabapentin, pregabalin can cause drowsiness, and sometimes
mhm,
a person just needs a dose at night,
mhm.
or a lower dose in the morning and a higher dose before bed. Um, so that's something to take into account also. But I agree, it's hard. The opioids are really hard also.
Yeah.
I'm sure I'm not the only person on this call who has patients who have been on chronic, longstanding opioids for 20 years or more, and maybe it was started by a different physician and you've taken over their care. That can be a hard thing to contend with, but it is impacting their brain function as they get older.
Yeah, for sure. A few questions. Is there a specific viral load level in the CSF that you would be concerned about? Like, do you expect a zero or is there a threshold when you're concerned? And what do you do with that now if you would
Thank you
find
for
that?
that fantastic question. So, anybody who has detectable virus in their plasma, we expect them to also have detectable virus in their CSF, usually one order of magnitude lower. But if somebody's undetectable in their plasma, they should be undetectable in their CSF. If they're not, you have a problem. So that's what's typically referred to as CSF escape. It's pretty uncommon with current regimens that are highly penetrant into the CNS. And it's not something we have to go and look for outside of maybe a more acute presentation, a more neuroinflammatory presentation. It's not part of my standard workup of somebody who's coming in with months to years of cognitive issues. But if we do find that, then that is problematic and may be the cause of their symptoms. And we don't have a straightforward intervention, but I'm happy to talk to you more about that.
Yeah. And then one question on whether the study you showed with the zoster vaccination, is that effect also if someone had shingles, or is that the vaccine itself, or is there a way to tease that out of the study?
Oh, that's such a fantastic question. I don't believe that these population level studies had separated out for people who had had prior shingles before or
Mhm.
not. So I would estimate, um, I can't answer that, but I think it's a brilliant question and a great opportunity for secondary analyses.
Yeah. Yeah. And then another question just on potential benefits of duloxetine for peripheral neuropathy with less cognitive side effects compared to the
Yeah, it's a
gabapentin.
great idea. Look, there are alternatives, right? I
Mhm.
love that. TCAs, each has their own potential for drug-drug interactions. With duloxetine, you have to worry about that also. But certainly, it's a good idea to try alternate regimens if a person is having side effects from the more standard treatments, which are sedating.
Yep. A question about hand, and that it seemed to be emphasized in people with HIV who developed neurocognitive decline. When are you associated, or when are you concerned for hand versus age related? And I know you mentioned a shift towards away from using hand,
Yeah,
but
Alex, I really don't use the terminology of hand anymore. I try not to teach it to my students, and I really don't talk about it with my patients because I don't think it's useful anymore. Um, as I mentioned, these are criteria that were solely developed for research studies. And the way hand is classified is if a person with HIV scores abnormally, meaning below what age, education, race matched control would on tests in two or more domains, then they're considered to be impaired, even if they're completely asymptomatic. And I'm sure many of you have seen these graphs where they show that the vast majority of quote unquote hand in the ART era is asymptomatic neurocognitive impairment. When you tell that to someone outside the field, they would say, well, that's an oxymoron. What does it mean to have asymptomatic impairment? And I think it's a reasonable concern. Is there potentially some utility in identifying those asymptomatic impairments? Are they actually pre-symptomatic? Yes, and there's some active research on that. But the problem with hand is that it tells many of our patients that they're impaired when they're not. I think it increases stigma. It has led to people with HIV, for example, being excluded from certain jobs, like being pilots in the UK, because of this lore, sort of, that people with HIV have brain problems, even if they're on ART. So I think it's more useful to just think more generally about, does this person have a cognitive problem and how can I help them? And that's
Mhm.
why I love the Kaiser Permanente studies, which focus on age-associated dementia. So all dementias, because ultimately that's what we care about, right? Is people having cognitive impairment, whether it's augmented by their prior legacy effects of HIV. Certainly it is, we know that. Um, but I think the key is to figure out if they're impaired or not, and not necessarily to say it's HIV dementia versus something else.
Yep. No, that's great.
I don't know if that answers your question.
I think that was great. Alex says driving, so probably can't
Okay.
respond, but no, appreciate your time and patience. Even though we had some technical glitches, all was good, and we got through slides just in time. So with that, I'm going to turn it over to Dr. Medimo for some closing remarks.